This is first of two sessions on what's it called, important and frequently used ED drugs. This first drug that we're going to talk about, we did cover a little bit last year, but we got some new information, and a lot of you weren't here last year, so hopefully it'll be worth your time. So you have this person comes into the emergency department, they're on warfarin, they're bleeding actively, and their life is being threatened, and the quiz question is, what are you supposed to do? What therapy do you give this person? And the answer is, for the board review exam and all that kind of stuff, the answer is fresh frozen plasma, fresh frozen plasma. Yeah, you can give some vitamin K, not going to work, so you have to give this immediately because they're bleeding and you have to do something right away, so you give fresh frozen plasma. That is the answer. It's always been the answer. And then now the next question is, so say for the sake of discussion, this person is 100 kilograms. How much fresh frozen plasma would you ask for? Anybody? Give me a number, please.
4 units.
4 units. Oh, that's pretty aggressive. Anybody else? Give me a number. Wouldn't most of you pick 2? 2's a nice number. It's an even number. You certainly wouldn't pick an odd number. You wouldn't say 1 or 3. You would pick 2 and say, okay, fine, send me down 2. And if you did that, the question would be, is that an adequate amount? This doctor said give 4. The issues with fresh frozen plasma are pretty straightforward. Number one, it has to be defrosted. It's going to take some time to do that. This person's bleeding pretty badly. Now, some hospitals have machines that can defrost this stuff kind of quickly. Other hospitals don't, so you're going to have to wait. The other thing about fresh frozen plasma is the amount that you need to give. Even if you have an INR of 3 or 4 or 5, it's going to take a substantial amount. And how much is it? 15 mLs per kilo. 15 mLs per kilo. We're talking about a 220-pound, 100-kilogram person is 1,500 mLs of plasma. So he was close. He said 4. You need to be at 5 for this person that I was talking about. That's 1,500 mLs of stuff that's got to be infused rapidly in this person who's exsanguinating. It has to be defrosted. That's an issue. So you're going to have some issues about how long is it going to take to give 1,500 mLs of something while this person's exsanguinating. There's the potential for fluid overload, but we don't have to worry about that in this bleeding person. That's not a big deal. But more importantly, it's not as effective as something called prothrombin complex concentrate. Anybody ever used prothrombin complex concentrate in this room? You've used it and you've used it? So this is, are you an Aussie, sir, doctor? Are you an Aussie? Okay. So are you Australian as well? No? So you folks have used it, but nobody else in the room of any consequence, doctor there has used it. But the fact of the matter is most people have never used this drug and probably have not heard of this drug. But you got somebody who's now exsanguinating, and their INR is 5, 6, 7, or 8, and you basically have to be aware of this drug. Why do you have to be aware of this drug? In 2005, the British Committee on Standards in Hematology, and I think it's written in your book there, the British Committee Standard Hematology said in the setting that we just talked about, life-threatening bleeding on warfarin, reversal of anticoagulation, is a direct quote, in patients with major bleeding requires administration of a factor concentrate in preference to fresh frozen plasma. Requires, strong word, in preference to fresh frozen plasma. Well, that's what the Brits, what the heck do they know, kind of thing, you know? But in the United States, the American College of Chest Physicians in 2004 came out with guidelines for the treatment of people in the same setting we're talking about. And in their 2004 guidelines, they basically said, give prothrombin complex concentrate, and they made no mention of fresh frozen plasma either. So there were 2 now who basically said that. And now we have this big disconnect. The Americans and the Brits say to give this in this life-threatening situation. You're the ones who are going to give it, and you never heard of it. Most of you have never heard of it, and maybe your hospital doesn't even have it. In 2008, after we did the course last year, because we talked a little bit about this, the American College of Chest Physicians came out with new recommendations regarding the treatment of this person who's exsanguinating kind of thing. 2008, here's what they said, direct quote, although fresh frozen plasma can be given in this situation, immediate and full correction can only be achieved by the use of factor concentrates because the amount of fresh frozen plasma required to fully correct the INR is considerable and may take hours to infuse. Now, this appears to be, a backpedaling a little bit. In 2004, they didn't even give you the option of using fresh frozen plasma. Now they say, okay, you can use it, but they basically say it can only be achieved by using factor concentrates. So now there's this disconnect. Recently at our Pharmacy and Therapeutics Committee meeting at our hospital, the pharmacist there basically read the hospital's guidelines with regard to the treatment of people who are bleeding and who have undercoagulated kind of thing. And it said to give fresh prothrombin complex concentrate. So I asked the pharmacist, do we have prothrombin complex concentrate? And he shrugged his shoulders, kind of thing. So this is an issue because, in fact, I think you need to go back and say, we need to get this stuff. We need to use this stuff. This stuff needs to be available. It's expensive. Maybe every hospital doesn't need it, but the hospital down the street can share it with your hospital, kind of thing. But the fact of the matter is that if somebody exsanguinates in front of you, kind of thing, and you're putzing around with giving 1 or 2 units of fresh frozen plasma, you may have a problem in terms of people saying, "Why'd you do that?" Because it is so unequivocally advised that you not do that. Life-threatening situation. What is this stuff? Prothrombin complex concentrate is a pooled plasma-derived factors 2, 7, 9, and 10. Factors 2, 7, 9, and 10 are the 4 factors that Coumadin and warfarin basically screws up your liver's ability to make. The 2, 7, 9, and 10 are the key factors on the extrinsic limb of the clotting cascade. Your liver doesn't make them when you give the warfarin kind of thing, 2, 7, 9, and 10. Number 1 is a paper, manufacturers, most of these papers are manufacturer supported. You would think, that's going to be logical. They're trying to show that their stuff is good and it works. So number 1 is a single dose. Single dose, have you ever seen a bottle of this stuff? The bottle's this big. You're going to give a little squirt of nothing. There's no volume of any consequence. Number 1, single dose of Buraplex is the name of this, trade name of this stuff. Reversed elevated INRs within 30 minutes in 43 adults. Within 30 minutes. Most hospitals, you're not basically even going to get that fresh frozen plasma out of the refrigerator in 30 minutes. Basically, this is reversed it in 30 minutes. These are people who had bleeding or they were on Coumadin and they needed immediate surgery. So we have to undo this stuff. A more impressive paper is number 2, a 14-study review. The addition of fresh frozen plasma added nothing to the benefits achieved by prothrombin complex concentrates alone. Head-to-head comparison showed prothrombin complex concentrate to be superior, more rapid, and complete reversal. One of the problems with these drugs is that if you're going to give something to reverse this coagulation situation, maybe you might overshoot and start creating some kind of hypercoagulable states. And the answer is, yeah, that's possible. So how many people got into trouble in study number 2 with what they thought might have been a coagulation over excess might have been caused by this drug? Of 460 patients, which is a huge study, treated with this stuff, 7 had thrombotic complications, 7 out of 460, that's 1.5%. It is a hiccup. So don't let people, now we'll show you some other papers that may be a little worse, but it is not something like, well, 1/3 of the patients are going to have or be at risk. No way.
Is it expensive?
Yeah, it is. We're going to get to that. Number 3 is an in vitro analysis by the makers of Buraplex of their product versus 6 others, and lo and behold, their product was the superior product. Surprise, surprise. But here's another paper, here's another drug, manufactured, it's called Proplex T. That's number 4. 58 patients needing rapid reversal of warfarin. 36 of them had bleeds in their head, and 11 had GI bleeds. Listen to this now. The mean INR was 11.7. Wow, up there. In less than an hour, the mean was 1.4. You're not going to get that with fresh frozen plasma. It will not happen. At 24 hours, the INR is 1.5. So one shot of this stuff, it lasts, it works. The INRs were below 2 in all but 2 of the patients that were studied. That was 58 people, within an hour. Possible complications in terms of this coagulation-inducing effect, 4 people possible. 2 of them had heart attacks, and 2 of them had venous thrombosis. Well, the venous thrombosis is pretty obvious. That's got to be related to this. Heart attacks, non-Q wave, you're going to be, that's stretching it a bit. If you accepted all 4 of them were related to this drug, that was 4 out of 58, that's 6.9%. One paper, 1.5, the other, which is a huge paper, this paper, small paper, 6.9. So yes, maybe small risk, but it is small. Now remember, 36 of these people were bleeds in their heads, and you've seen the papers that talked about factor 7A, trying to give those people who are bleeding in their head, try to make that hematoma as small as possible. And the outcome in those cases were that patients didn't do any better, but the hematomas were smaller. But because we made the hematoma smaller, that was a surrogate. That's what we were trying to achieve in an attempt to get this person's outcome better. The outcomes were not better, so the studies with factor 7A in people who were bleeding in their head, yes, the hematomas were smaller, outcomes were no better, studies were discontinued because it wasn't working to accomplish the clinical goal. Number 5 is a brand new abstract. This is done in December of 2008. This is like 6 weeks old, this thing here. This is from the American Society of Hematology, their annual meeting. It was an abstract presented at that meeting. First of all, they noted in this abstract that 1% of patients on warfarin experience life-threatening bleeding a year. 1% a year? Life-threatening bleeding? You take this stuff for 5 years, that's 1 out of 20. That puts this in some perspective, and we get to see all of the warfarin problems. They all come to the ER, so we're kind of sensitized to this. But in any case, they studied prothrombin complex concentrate, factor 7A, that stuff that is made by Novo, Novo Nordisk, and fresh frozen plasma. And they did an in vitro, in glass, experiment to look at generation of thrombin, which is the kind of the bottom line here. We need to make some of this thrombin kind of thing. The conclusion of this paper, where there was no financial ties to the manufacturers of any of these drugs, prothrombin complex concentrates fully reverse the effects of warfarin when compared to standard doses, I don't know what that necessarily means, of fresh frozen plasma and factor 7A. So, and getting down to the cost of this, I found a paper in the journal called Anesthesia, published in August of 2007, where this stuff was, prothrombin complex concentrate was used in the treatment of Jehovah's Witnesses, and it's one of the options that you should be aware of. Somebody's bleeding and they don't want to take blood, maybe you can give them and reverse these things. Now, remember, it does have factors 2, 7, 9, and 10, human-derived stuff, and so it's not like genetically derived like factor 7A. In any case, the cost, U.S. cost was $850 for this stuff. Factor 7A was $6,200. Everybody knows 7A is really expensive, $6,200. This is $850. This was the price in England. Whether it's the same price, it's going to be certainly expensive. And surprisingly, the cost for fresh frozen plasma is really pretty inexpensive. You get it from the blood bank kind of thing. You get it from the American blood banking or whatever, whoever gets the Red Cross. It's like 30, 40, 50 bucks. Nothing in the ER is that cheap, but that's what it basically sells for. So here's an example of where what the community is doing as standard care, giving fresh frozen plasma in these cases, is refuted by all the literature. If you start going to all of the papers like we did last year on this topic, you won't find any papers that say fresh frozen plasma is better than this stuff. And what is kind of strange is, although the 2008 recommendations of the American College of Chest Physicians says, they now added back a little bit, backpedaled a little bit on the fresh frozen plasma. Yeah, okay, but the prothrombin complex concentrate is really better. That's the way to go. There's no new data to support, them embracing this when compared to what happened 4 years ago. And one of the things that I thought of, maybe this is true, I don't know, is they realized that they created a guideline that nobody in the United States is using. And so maybe they had a backpedal, say, okay, well, we'll throw this fresh frozen plasma in there because this is going to be used against all these doctors who don't use this stuff, and this person bled to death, and why didn't you use it? And these guidelines of the American College of Chest Physicians say right there, use the other stuff, and you didn't use it. It doesn't even say fresh frozen plasma, because in 2004 it said, didn't even say it. So I think they may have done it just to be politically expedient so that people would not get nailed as aggressively as they might. So that's something for you to go back to your hospitals and say, listen, where is that stuff? We need to know where it is when we need it. The next thing, the drug is Desmopressin. Desmopressin is synthetic antidiuretic hormone. Synthetic antidiuretic hormone. Antidiuretic hormone, antidiuresis. If it was diuresis, you make you pee. This makes you not pee. So antidiuretic hormone, you don't get up in the middle of the night, or at least most of us don't, get up in the middle of the night to pee, because during the night you make a lot of ADH comes out, and you can sleep through the night without peeing. And they give it to kids to prevent or to decrease the issues of bedwetting, same kind of thing. The stimulus to urinate, it goes down with this stuff, antidiuretic hormone kind of thing. Well, you're not going to likely have any emergency situations where nocturnal enuresis is a problem, kind of thing. So you wouldn't be giving it for that reason. But it does some other things. Like it also treats diabetes insipidus, which is diabetes it's kind of strange. It's about urinating too much. In diabetes, you got all that sugar and it causes osmotic situation and you're peeing a lot. So this is diabetes insipidus in the setting of head trauma, but we're not going to do that. It's not going to be something on our watch that we're going to be giving. But it does do one other thing that is important. It is used to treat hemophilia A, von Willebrand's disease, and thrombocytopenia. So you have some person coming to your hospital who has hemophilia A and they're bleeding kind of thing, and you're supposed to give this stuff, this drug, because it's got nothing to do with antidiuretic effect of this drug at all. It's about releasing factor VIII. Factor VIII is, the problem in hemophilia A, factor VIII. This drug, the name of this drug chemically is desamino-D-arginine vasopressin. Desamino-D-arginine vasopressin. D-desamino, D arginine vasopressin, Ddavp. Ddavp is what they call it for short. It's very interesting, however, and this is a good cocktail conversation. This will get you a lot of friends. Ddavp is a trade name. It is a trade name. Normally you would think that, we just took the initials and that's what everybody calls it. It is a trade name for this drug. Some company cornered the market and said, this is what we're calling our version of this drug, Ddavp. So when people talk about Ddavp, they're not talking about or properly using a generic. They're using the name of one company's version of this synthetic drug. What does this stuff do? This stuff basically does a couple things related to factor VIII. Factor VIII is carried by von Willebrand's disease. Factor VIII is carried by von Willebrand's factor. This drug makes von Willebrand's factor come out of blood vessels. One of the stimuluses to generating clot formation is a blood vessel gets injured and starts releasing, this injured blood vessel starts releasing von Willebrand's factor around this injury. Von Willebrand's factor does two things of importance. Number one, it basically facilitates platelets' ability to see where they are. And once these platelets see, hey, we're in an environment of an injured blood vessel, they agglutinate and start triggering the intrinsic limit of the clotting cascade. The intrinsic limit of the clotting cascade is about platelets aggregating and releasing chemicals that makes this clot form intrinsic limit of the clotting cascade. So basically, von Willebrand's disease allows these platelets to see really, really sharply, hey, we're not where we're supposed to be kind of thing here. There's a broken blood vessels leaking out this von Willebrand's factor. Let's start this process. The other thing that von Willebrand's factor does is it carries factor VIII in the serum. So the more factor VIII you have in the serum, you need a lot to von Willebrand's factor. You bring out a lot of von Willebrand's factor, it scavenges all the factor VIII it can, carries it around. So the idea of factor VIII being used to treat a hemophiliac patient comes into your emergency department, they got a bad headache kind of thing, you're going to get a CAT scan, you're going to call the hematologist, all this other stuff. But in the meantime, you're supposed to give Ddavp. Ddavp will triple, quadruple the amount of factor VIII through this kind of backdoor process of releasing von Willebrand's disease, von Willebrand's factor, which is the carrier of factor VIII in the serum. You have a lot of carrier, it scavenges, gets as much factor VIII as possible into the serum. And the third thing it does that we might use it for is somebody's got a platelet count of like 10,000. They're bleeding and their platelet count is very low. What reason, I don't know. This allows those platelets to work better than they normally would. We give Ddavp, platelets now have a particularly sharp ability to see where they are and do their job. A lack of von Willebrand's factor basically means your platelets don't work as well as they should. People who have von Willebrand's disease basically have the platelets that are not working so good because they don't recognize when they're in the environment of a blood vessel that is leaking and is injured. So the fact of the matter is that the ability of platelets to work is adjusted by the von Willebrand's factor, which is released from broken blood vessels. So that's one of the things, that would be you. Factor VIII problem, hemophilia A, which is by far the most common version of hemophilia. The emergency treatment of that, all the books say Ddavp. And that's one of the reasons why we would use this uncommonly used drug. Anybody use this for factor VIII kind of problem? Anybody come into your department? Yeah, you've used this? It's in the books. You go to the books. That's what it says to do kind of thing. So this is an infrequently used but important drug in the setting of emergency medicine because usually people who have hemophilia have the drugs that they need, they know where to go kind of thing, and they might come to your department and you're not prepared for it kind of thing. This is what it's about. And then lastly, Vasopressin. Vasopressin is a vasoconstrictor, and it made a fair amount of press recently because people were using it in the setting of cardiac arrest. Instead of giving epi, they were giving vasopressin or vasopressin and epi, and they were thinking that they were getting better results when they used vasopressin than epinephrine. So papers go back and forth, yes or no. The definitive paper on this is number 7, however. 2,894 cardiac arrests, double-blind, placebo-controlled, no benefit of vasopressin over epinephrine alone. No benefit. So we're not going to be using it for that. But what you might be using it for is paper number 8. Paper number 8 talks about its use in the setting of anaphylaxis. Anaphylaxis basically is vasodilated. You turn red as a lobster, vasodilated. You're leaking all of this plasma stuff into your interstitial space, so you get edematous, your tongue swells up, your lip swells up, you got all of these hives, your plasma volume goes down quickly and within 10 minutes and you could die. So this is anaphylaxis. Here are 6 case reports, and there's actually, since we did this chapter, another paper that's come out that talked about the use of vasopressin in refractory anaphylaxis. Every one of us has seen somebody in anaphylaxis. We've it's one of those things where it makes you really, really nervous in this subset of cases. Maybe you should be aware of this. It is kind of like a epinephrine surrogate. In these cases, these patients were supposedly refractory to usual therapy, which is obviously epinephrine, and they responded to vasopressin. A series of case reports, but how much data do you need to give something that is not likely to hurt somebody and may save their lives? You don't need a lot. And lastly is glucagon. There are 3 issues with glucagon. Number 1, causes your liver to release. You got the glycogen in your liver, it breaks down glycogen to glucose, so it's one of the things that we do in people who are hypoglycemic. You can give this drug, that's okay. The second thing is a smooth muscle relaxer. Some people have used it in the setting of ureteral colic, obstruction of the esophagus with some chicken or something like that. And the third thing it does is it releases cyclic AMP. Cyclic AMP is the mediator the ultimate mediator of the adrenergic nervous system. In that, we give somebody a shot of adrenaline. A shot of adrenaline increases the amount of cyclic AMP. So all the things that we give adrenaline for, anaphylaxis, bronchoconstriction, that kind of thing, epinephrine induces the production of cyclic AMP. Cyclic AMP is the factor that causes these end results. In the old days, we used to give aminophylline. A long time ago, we used to give aminophylline for the COPDers, the asthma patients. What did aminophylline do? Aminophylline inhibited the breakdown of cyclic AMP. So you would give both. You would give shots of epinephrine for the asthmatic, and then they would be given these loading doses of aminophylline to create as much cyclic AMP as possible to create these beneficial effects. So you would give both drugs. But the bottom line is it was about cyclic AMP. So this drug increases cyclic AMP levels. And so everything that epinephrine would do, theoretically, in terms of good things and bad things, would be done by this drug. So the three things are raises your blood sugar, smooth muscle relaxer, supposedly, we'll talk about, and then, but most importantly, in terms of emergency situations, we're talking about creation of cyclic AMP. Number 9 is a general review of this stuff and talks about its effects. The part I'd like to focus on is potentially the side effects. Nausea and vomiting, okay, well, that's got something to do with smooth muscle. Hypokalemia, why would it cause hypokalemia? For the same reasons that epinephrine would cause hypokalemia. Adrenaline drives potassium into the cells, changing the ratio, intracellular ratio, 30 times more potassium intracellular than extracellular, drives it into the cells. So it causes a transient hypokalemia. It may cause hypoglycemia for the same reason, kind of thing. And lastly, hypertensive crisis. Why would you get? Well, you're given adrenaline. Maybe that would cause somebody to have a hypertensive crisis. So those are the downsides. Anaphylactic shock in people in beta blockers is the traditional area where they talk about the use of glucagon, because it generates cyclic AMP, which is the transmitter used without, but you don't need the adrenergic nervous system. So if somebody's got a situation where they have a beta blocker overdose or they have anaphylaxis under the influence of beta blockers, then you have to remember we have to give something. The epinephrine system is compromised. We're going to bypass the epinephrine system. Yeah, you're going to still give epinephrine. It's not going to work as well. You're going to go directly to the releaser of the mediator, cyclic AMP. So we're going to give, this is considered to be one of the indications for the giving of glucagon, beta blocker overdose, anaphylaxis, and association of a beta blocker treatment as well. And then the last papers there talk about its use in esophageal food impaction and kidney stones. Basically, it says it really doesn't work there. It really doesn't work. I use it routinely for somebody who's got the chicken in the esophagus, the older person. They come in and they got the spit bowl there and all the saliva is coming out. You don't need to be a rocket scientist to figure out what's going on there. And you give it and maybe that makes them a little nauseous. If they vomit, great, maybe to push that thing out. I'd rather do that than have them be subjected to have a big tube going down their gullet by some GI doctor in the middle of the night. So that's reasonable. And all of these studies say it's hard to know whether this stuff makes any difference because you're usually using it in conjunction with some other things as well. Like, some people use carbonated beverages in the blocked up esophagus patients. I prefer Dr. Pepper. It's a medically oriented carbonated beverage for these cases, in a randomized double-blind control style. It was far superior to 7-Up. So those are 3 drugs uncommonly used, which can be potentially life-saving in the emergency department setting. All right, let me stop here.